Yeah, oh, sorry. Can everybody hear me?
Blair just wanted to say a few words as well.
Yeah, so I'm not gonna repeat what you just said, but so I'm an associate professor at the BU School of Global Studies. I've been an associate director at the Human Capital Initiative, where we're trying to be interdisciplinary and bring anybody and everybody who works on issues related to human capital at BU. And then I'm also the director of the program on women's empowerment research, which this project and a whole other set of projects are actually situated, and I'm happy to provide more insight and inputs on other projects, not just the one that I present from Malawi, and I'm happy to talk about anything. And so, and then also I'm one of the co-editors of Studies in Family Planning, which also is where a lot of this work is situated. In other past, not quite past lives, but lives, I also used to be a population policy analyst. I used to work in DC, work with Palladium and the Futures Group on the large health policy projects that USAID and other funders have supported for global health and global development research. And I also used to be an upper and middle school teacher, and I absolutely love teaching AP economics and Spanish literature, and this would have been my 18th year teaching had I not been a little bit selfish and decided to go back to grad school. Yeah, and so that's a little bit about me. What do I do beyond just family planning? And what I'm going to be presenting today is, if I had to define myself, I'm an applied economist who really looks at the intersection between population health and social and economic development. In low and middle income settings, I look at both the causal pathways. I look both at the consequences as well as the causes of population health and well-being. A lot of my work is situated in economic demography, and a lot of my work is really focused on women's empowerment and well-being. So how do policies, programs, and interventions that seek to be empowering to women and children and their families, to what extent are they actually empowering, and how can we tell? A lot of my work is looking not only within health, so not only within maternal child health and family planning and reproductive health, which is what I'll present today, but also I'll give you some insights about the cross-sectoral work that I'm doing, particularly around women's mobility, social protection, and other spaces that I'm also engaged in. I have a lot of interest in measurement, and that interest has only been growing, particularly looking into family planning and reproductive health, which is kind of going through a reinvention period on, they're looking a very introspective period on, are we measuring the things that we want to measure? Are we measuring the things that should be measured, and how can we tell? Because what gets measured gets done, what gets measured gets treasured. I have all these sayings that I will constantly throughout the presentation. This is how I also teach my students, but we want to value what we measure, and as a result, particularly within the sexual and reproductive health space, given the current climates, given what's happening not only within the US, but also globally, how can we understand sexual and reproductive empowerment? And how can we particularly embody person-centered approaches to measurement in the family planning and reproductive health space? So I've been working on some, looking particularly at the alignment between preferences and what people want and behavior, what people do. Because I think particularly in this space, that alignment, that concordance is very salient as a measure of welfare and well-being. So I can talk a lot about my work in measurement as well. This is where I currently work and where I also worked in the past. So everywhere in red is where I currently have projects. So I used to work in Latin America, in Peru, Bolivia, and Colombia, and then now I've been moving east ever since. But I now actually have some new projects on migration and reproductive health in migrant populations in the Venezuelan-Colombian border. But a lot of my work is currently situated in East Africa, particularly Malawi and Kenya, Tanzania. I have projects with Maria Dieci, if anybody works with Maria here in Uganda. I have some new work on menstrual health in Burkina, and then I have some work on women's social networks and intergenerational work in India. So looking at how extended household members, particularly mothers-in-law, play a very important role in determining women's healthcare utilization, access to health services, and just health behavior more broadly. So I do lots of different types of work. particularly related to trials. So I am an applied economist who works in like development spaces. So intervention research, process evaluation, impact evaluation. So I have RCTs that I run, but I also do quite a bit of qualitative and mixed methods work. So a lot of like all of my projects, and I don't present all of the work here, but they're all fundamentally embedded within qual and quant mixed methods oriented work. So I've done some qualitative work on how to understand and conceptualize women's work and how women themselves think about how they work and how they are productive. I also do a lot of work on sex and reproductive access, like qualitatively. But I also, as an economist, I also do structural modeling. I love to write some models out and also to do some dynamic like programming. And then, of course, measurement and estimation, as I was discussing. So I'm not exactly sure where I fit, but I would say that I'm kind of like global health, economic demography, public health, and applied economics, somewhere in the intersection of these spaces. So for that reason, I publish everywhere, and that's what I'm really grateful to actually have that opportunity to publish in different spaces. So of course we can like look at where we publish in sexual reproductive health and public health, but also I've had some opportunities to work in applied statistics and agricultural economics and family planning, and also in population development more broadly. So what I'll present today, and this is kind of a preview, is a study. It's actually one of my longest standing studies. I actually started this as a graduate student, a first year grad student. And after many, many years of setting field sites up, like policy engagement, working with like the ministries of health in the context where we work, the communities, being able to like do a lot of formative work, we actually have several outputs from a trial that looks at improved access to family planning and reproductive health services for pregnant and postpartum women. From that study, I also was able to leverage other studies because I do a lot of work in behavior, and I'm also very interested in like behavioral approaches to health and health decision making. So I'm a PI on a behavioral health trial trying to understand what does user-centered decision-making look like in the health space? Like how do people actually make decisions either autonomously or in conjunction with other people in the house, in their households and in their communities, so partner involvement and reproductive health decision-making. And I would be remiss if I said this is absolutely not an individual project. Nothing like this is, it takes more than a village to do this type of work. And I would have to say that none of it is really possible without the direct engagement and support from all echelons of engagement. So not just the Ministry of Health and Reproductive Health Directorate of Malawi, but also with the NGOs who I've been working with and partnering with for the last 10 years, but also the women, the programs and the communities where these projects are situated. Incredibly important to be engaged with them from the outset. So I've been like, the communities themselves are the direct recipients and also the biggest stakeholders in all of the work that I do. So I'm going to present essentially what would have been 3 separate projects, but actually is all connected by the same intervention study, which is on a family planning intervention that was rolled out to pregnant and postpartum women starting in 2016. And we were able to follow these women, these cohorts of women, their children, their families over time, all the way actually up to 2023. And I'm going to present some of the results of this impact of this intervention on not only first stage outcomes like healthcare utilization, contraceptive use, and birth spacing and fertility, but also children's human capital. So how did this intervention affect children's health and well-being, and how did it affect women's health and well-being as well? So women's work. Why family planning? It's a kind of a particularly interesting time to talk about family planning and reproductive health, given the current context in the US, especially over the last 3 to 4 years with Roe v. Wade. But family planning has received, for better or worse, significant attention in the academic, policy, and program spaces. The 1994 conference in Cairo, the International Conference on Population and Development, really it transformed the discourse around family planning from one where it was a population control narrative and discourse to one where we're thinking about reproductive rights, reproductive justice, contraceptive autonomy, the decision-making power that women and couples should make, where family planning in its most fundamental form is how do women and couples and families choose if to have children, when to have children, how many to have children, like how many children to have, all of that decision-making and how much can we essentially empower women and couples to be able to make those choices in the most optimal way that they see fit based on their own preferences. And that is what was really emphasized in the 1994 conference. And then subsequently with the 2012 London Summit on family planning, and then the SDGs, where SDG 3.7 is on universal access to sexual reproductive health, and then Family Planning 2020, which are these large-scale programs globally to be able to improve access to family reproductive health services. So why are we focusing on family planning? So from the first, hopefully I've motivated the first most important goal, which is the intrinsic value of family planning. It's the goal to be able to choose childbearing and fertility is a fundamental human, it's a fundamental human tenet. And like how that reflects reproductive rights and autonomy should be of intrinsic value for supporting the family planning and reproductive health program. But also, there have been a number of other possible contributions and impacts of improved access to family planning and reproductive health that go beyond the intrinsic value of securing rights, which include the promotion of social and economic outcomes for not only women, but also the children and families who are also receiving services. And this idea of the population to health to development connection really comes from theories of the demographic dividend, where these theories are very much at the macro level, where as populations change, as fertility changes, as women and couples are able to concord and align their fertility preferences to their actual realized behavior, how do those changes cascade into improved health for women as women are able to space and time children more optimally for themselves? How does that cascade into women being able to return to work? So the opportunity cost of childbearing, how does that also cascade into other dimensions of social well-being, right? So that demographic dividend story really comes at the macro level, but in a lot of contexts, we actually see evidence for the dividend, right? At the micro level, at the household level. So if we look at, for example, there's a lot of literature in the demography space where, we've heard that in sub-Saharan Africa, fertility is either slowing, like fertility transitions are slowing down or they might be stalling, but that might be true in aggregate. And we have to ask ourselves, is that a good outcome or a bad outcome? Like, I don't think we can put a normative spin on any one of those transitions, other than there are very different and very good reasons why those transitions might be different in different regions. But if we look at sub-Saharan Africa, for example, Ethiopia has, I think, a total fertility rate of around 5, but Addis Ababa, for example, the capital, has been under replacement rate for many, many years. So there's a lot of variation even within countries. So rural differences, socioeconomic differences that also reflect and embody a lot of the narratives and the theories that the demographic dividend posits, but at the macro level, that observed at the micro, with micro evidence. At the same time, there's another parallel, from the programmatic and the policy perspective. The WHO has a recommendation to say that women should wait at least 24 months between the last birth and the next pregnancy, before attempting the next pregnancy, in order to minimize the risks from short birth spacing, right? Where short birth spacing is associated, and I say associated, with potential maternal morbidity and mortality outcomes, particularly for women who have short birth intervals. And this is, of course, modified by health systems, capacity, etc. But in general, it's kind of like a U-shaped curve, where really short birth intervals are associated with adverse maternal health outcomes, and then very long intervals are also associated, but that often gets confounded with maternal age, because very long intervals means that these women might be older. So, but there are potential risks to maternal and child health from this short birth spacing. This is also coupled with the fact that there is a demand, there is a desire for women to better space and time pregnancy. So in the context of Malawi, when you ask women, when would you like your next child? Women qualitatively actually say, I want my next child when my current one can walk. And now what's actually happening is that as we start tracking women over time, qualitatively, we then now see women saying, I want my next child when my current one can go to school. So when you think about what that timing looks like, it's actually current one walking, it's going to be somewhere around the 3-year Like walking is as a proxy for independence, right? It's like around 3 years is actually kind of concords with a lot of what women are actually saying in terms of their preferences for trying to attempt a subsequent pregnancy. School is now actually extending to around 5 years. So like women are actually having more and more demand for longer birth intervals and longer birth spacing, particularly as they are investing more in children over the earlier trajectories of their life course. So there are a lot of social and economic implications for women, for mothers, and for families to be able to time their childbearing as they see fit, because it allows women to return to the labor market, it allows women to invest more in children who are already born, and so there's a lot of interesting implications that actually have direct welfare consequences for women and their families. How can that be facilitated? Well, family planning services and reproductive health services can help facilitate that birth spacing and reduce the risk of unintended pregnancy and particularly mistimed births, where in Malawi, for example, about 40% of births are estimated to be mistimed. It's that women actually wanted to have children, but they wanted to wait a little bit more before they actually had them. So the timing concept is much more important in this context than, for example, the limiting concept, which is more prevalent in South Asia and in Latin America. So when we look at the evidence, actually there's quite a bit of mixed evidence. A lot of the evidence actually for family planning, the impact and the effectiveness of family planning programs typically comes from two sources. It either comes from the Matlab study in Bangladesh, which is a long-standing DSS site, and I think a lot of people here know it quite well. And then again, the Navrongo study in Ghana, which was a large community-based trial that has been also part of the Navrongo demographic surveillance site. The challenge with both of these studies is that they were both quasi-experimental in that treatment control villages were never actually, it was never quite determined how they were selected. And when we actually look at some of the data from the original DSS sites, you actually see pretty significant imbalance. So like treatment villages were already doing quite well in receiving services before they were actually selected to receive them. And then typically what happens with family planning trials or with studies is that the outcome of interest typically stops with contraceptive use, with utilization. There are very few trials that actually go beyond contraceptive use and actually look at what are these outcomes downstream, looking at beyond just service uptake and utilization. And the other challenge with family planning is that because of the way that a lot of programs are designed with family planning is often packaged in with other maternal child health services, with vaccinations, etc. So in Matlab, it's very hard to disentangle the family planning impact, the improved access to family planning reproductive health services from tetanus toxoid vaccinations, from child vaccinations, from child health investments, all of which were happening and being rolled out at the same time. So that's been a challenge to disentangle family planning from other programmatic impacts. So it's hard to know what the return on investment would be from that particular domain and dimension of health service provision from others as well. So generally, I think there is a need for more rigorous impact evaluation. So what do? We conducted a trial that assesses the causal impact of a multi-component family planning intervention on first stage utilization to see whether women have an interest in taking up services, whether there's a change in method mix, whether there's a change in the distribution of services that are actually utilized. And then what we really powered for was the pregnancy and birth spacing outcomes. So the trial was really powered to say, are women able to meet their spacing goals based on what they stated from baseline? If we follow them 2 years later, are they minimizing their risk of a short birth interval or short interpregnancy interval? And then we're able to follow these women for longer and children to be able to assess child health, physical growth, and development, like broader measures of development. And we also are interested in connecting to the social and economic outcomes. So we actually measure women's labor force participation, we measure women's work, women's own health. And so I'm happy to talk about some of these outcomes as I present them. So the experimental setup, we're working in Malawi. The total fertility rate in Malawi is 4.2 children per woman. As I mentioned, contraceptive prevalence in Malawi is already quite high. So this is an interesting situation where Malawi has, in the past 10 years, been it's been a family planning champion country where there have been a lot of investments, particularly from the international community, to support family planning reproductive health services. So contraceptive prevalence has been increasing significantly over the past 10 years. So the baseline, the margin to move on the baseline is already quite high to start. So this is an interesting scenario about what are the generalizability impacts and implications of our study for other contexts where prevalence might already, service access and prevalence might not already be as high. As I mentioned though, even though prevalence is high, 30% of women are reporting that their last birth was mistimed. So there's still a lot of margin to actually be able to close and improve access, even in contexts where the actual first order line of services is relatively better in this region. So what we did is we, at baseline, so in 2016, recruited 3 types of respondents. We went around urban Lilongwe, we worked in the urban capital of Malawi, and we recruited 2,000 women who are our main eligible women. And the criteria for recruiting them was that they were between the ages 18 to 35, so they were younger on their reproductive lifetime. They had not yet completed, they were not yet going to complete their fertility. And the reason why is because we could follow them for longer to be able to see how their fertility could change over time. They were married, they were living in Lilongwe, and the key criteria is that at the time when they were recruited, they were either pregnant or they were immediately postpartum. So within 6 months of postpartum at the time of recruitment, because to power for the birth spacing outcome, we wanted to look at the time to the next pregnancy. So we were looking for women who had just recently given birth to see whether they would be able to space and time their subsequent pregnancy. We also recruited financially knowledgeable members of the household, and also all children who were under the age of 6 were also recruited because we did anthropometrics with all women and children under 6. So height, weight, and anemia measurements, because we also measured hemoglobin to be able to see, are women who are able to space and time pregnancy, are they able to recover from their last pregnancy to be able, and through measures of anemia. So we have biomarker measurements of anemia here as well. The instrument here is the demographic and health survey as our baseline. So if you have ever used the DHS, one of the main complaints and challenges with the DHS is that it's a repeated cross-section. This is a DHS as a panel. And so it's a DHS as an annual panel, and it's also a DHS that includes labor market modules. It also includes time use modules, aspirations, and all these other measures of social and women's empowerment metrics beyond what a DHS would typically assess. So DHS typically has questions around decision making in the house. We went beyond that to think about aspirations, about mental health. So we have the PHQ-4 in here to also be able to assess these other impacts that are cascading downstream.
Mahesh, before you go on, could you say a few words about the financially knowledgeable member of the household, just about the design logic of that?
Totally. So in order for us to be able to assess household assets and income and consumption in the household, we wanted to be able to identify the financial, the most knowledgeable member of the household who was present at the time when we did the survey. Now, the challenge is that oftentimes the woman would report and the household reported would be the head of the household, the man, but men often are working, they're often not at home when we're able to find them. So we would try to track some of these men down who to be able to report back on household finances and household income. But in the absence of being able to track a lot of them down, because our main key respondent of interest was the eligible woman, the woman herself would report on behalf of the household. So we have data, we actually have quite a bit of variation in our study on who's reporting and how they're reporting, because from other studies, we know that men and women often report differentially on who's earning, who's saving, so there's a lot of interesting behavior that we can see on how assets and income and consumption behavior of the households can actually be reported. So we have data on that as well.
Thank you.
Sure. So it's a pretty straightforward trial that we recruited women and then we split the group. I mean, it's a randomized control trial with 2 arms into a treatment group and control group, and we gave a 2-year-long intervention to women who were assigned to the intervention group. And we did annual follow-ups. We've done 2 annual follow-ups, so a first-year follow-up in 2017 and the second year in 2018. We did a third year that was planned for 2019 to 2020, but then COVID happened, and so we did the third year follow-up in 2022. So there was a gap of a few years. And the other interesting thing, and I'm happy to talk a little bit about the previous results from the third year, is that the third year follow-up happened after the program had ended. So we can also see what, one of the main policy questions that often gets asked is, it's all well and good to analyze a program as it's being rolled out. What happens when programs end? Are there sustained impacts? Are there sustained longer term effects that are, or do we start seeing convergence between treatment and control groups? And we can answer some of those questions as well. So what's the intervention? It was a 2-year intervention that was developed directly in partnership with the Ministry of Health, with the Reproductive Health Directorate, with the multiple NGOs who work in the family planning and reproductive health space in Malawi. So this is with PSI, Population Services International, with Mary Stopes, or the Malawian equivalent of Mary Stopes, as well as the local communities where we work. So we did a lot of formative, qualitative work in the communities in the long way to say, what are some of the key barriers that women face to accessing services, particularly women who've recently had children. And a lot of the components that we developed were directly responsive to those, to the evidence that we were able to gather formatively. So there were 3 components that were part of this intervention over a 2-year period. One was counseling. So we hired trained nurses who were recent graduates from the Kamuzu College of Nursing in Lilongwe. And these nurses were actually trained by a master trainer from the Ministry of Health who would have trained normal family planning counselors on the current Ministry of Health curriculum in reproductive health. So one of the things that the ministry really appreciated was us engaging with them, because then they could actually say that this component would be easily scalable because they were being trained on the same curriculum that an FP trainer or a counselor would have gotten otherwise. And these counselors were providing 6 counseling sessions over a 2-year period. They were providing information, particularly on return to fertility. So a lot of women did not know that they could get pregnant as soon as 3 weeks after their latest delivery if they were not breastfeeding exclusively, or if lactational amenorrhea was not, if they were not following lactational amenorrhea. So a lot of women are already concerned because they would not be able to go, oftentimes women don't re-enter care. They don't actually seek postpartum and postnatal services until vaccination schedules kick in. But in Malawi, that's not for another 7 weeks. So that means that a lot of women might already be at risk of pregnancy if they've started resuming sexual activity following their pregnancy. So that was counseling session number 1. And counseling session number 2 was about breastfeeding and lactational amenorrhea, and also the importance of birth spacing and timing of pregnancy. And so if women have a preference for spacing and timing, how could that also contribute to their health, and how does contraception and how do family planning services actually facilitate that preference for spacing? Component number 2, transport. This was really an important one. Women were saying, well, if I'm a postpartum woman and I have a 3-month-old with colic, there's no way that I'm going to be traveling on 2 matatus and a bus to go and get family planning, even if it's free, even if it's high quality, simply because it's something that it's a preventative service and I don't demand it because there's no way I can get there. So what we did was that we coordinated a network of taxis, of private transport. So anytime you need a taxi in the long way, I know them all. Coordinated them all across the entire city, such that they would be able to provide door-to-door from women's homes to our partner clinic, the PSI clinic that we directly partnered with, for free for the entire 2-year period to provide specifically family planning and reproductive health services. And this was to directly eliminate the transport barrier. That was the real physical barrier to access that women reported. Now, we had a partner clinic, which was by PSI, so we partnered with Population Services International. And the reason we did that is we partnered with a clinic where we knew that the supply side could be controlled for. So because this was a high quality partner clinic where they had really good clinicians, they had all the necessary medical equipment, they had the full range of stock, so they were never out of stock on commodities. And they also could provide all types of services, including insertion and removal of services, they could provide the consultations, they could also provide additional facilitation. So the supply side was very well controlled for. So what we really were looking for was the demand response, like how, like conditional on there being the full availability of services, what is women's true latent demand going to look like for these services? So to facilitate that, we also had a reimbursement component where any family planning and reproductive health related services at this clinic were completely covered for free for the 2-year period. If women went to any other clinic, because something which I will also say is that women oftentimes would not necessarily go to our clinic, they were saying, I have a more local clinic nearby. All of those were also covered because we would coordinate with those clinics and follow up with those clinics after women had received services, and we'd be able to reimburse the clinic directly. So women were never paying out of pocket because we would coordinate that reimbursement service for them. So this is actually the brochure. Sorry, it's in Chichewa, but
Did women have a participation card so that the clinic knew that they kind of...
We created individual photo IDs for every woman, so we knew exactly how women were tracked for every single service. So one thing which I'm really happy with about this trial is, so from an impact evaluation and a process evaluation component, the critique of this trial is that it's a package service. And so one thing that everybody would always want to know is which of these components worked. And you cannot disentangle that because we didn't do a factorial design where we could randomize, because that just would take up too much power and sample. What we do have is all the process evaluation data from every single component, from every single interaction that women had. So anytime women got counseling service, we knew exactly what they received. Anytime women used the transport, we knew where they were picked up, where they went, what they received, and what kind of services were available for them at the clinic. And with our clinic, we were able to combine the clinic registrars and the administrative data, as well as the process evaluation data from our field team, because our field team were actually participating with the women. There was always a woman field manager in the car with women, because there's a gender concern here. All taxi drivers in the long way are men, and women would, one concern was that women would never get into a car with an unknown man. And we tried to find women drivers in Malawi, but they don't exist. So one of the things that we always had a female field manager in the car who women knew from the actual trial.
You could have had a driving school too.
I mean, we're really going. We're only going after that. We have it there, right? So that was what we were able to design, because women could then recognize our female field manager, and there was another woman in the car with them, so there was no social stigma from getting into a car where there was also another woman. So that was a really big component to facilitate that transport. And so one other thing is that one particular highlight from the reimbursement component was the treatment of contraceptive-related side effects. This came up a lot in our formative work. Family planning in many contexts is free. However, if women experience a contraceptive-related side effect, it is no longer considered to be part of the family planning umbrella on the Ministry of Health's free services. It's a medical expenditure, and women then have to pay out of pocket. And given that injectable contraception and hormonal contraception are the major methods of choice in these contexts, women often had a perception that they would incur a side effect, more so than the actual prevalence, but the perceived possible risk of a side effect was enough of a deterrent for women, such that they would not want to think about demanding services, because if they did take up the service and if they did get a side effect, then they would have to pay out of pocket. So we were very particular about the treatment of contraceptive-related side effects, whether women incurred them or not. So this is the family planning counseling brochure, and actually there's 2 panels, and each of these panels actually outlines each of the 6 different sessions that we had over the 2-year period. Women did not have to take up counseling across the entire period. A lot of women, we have a lot of variation, an interesting variation on when women wanted to take up counseling and what counseling messages did they want to focus on. So there's a lot of ways of exploring their, the variation and what the impact of counseling itself is on take up and the intent to treat in this program. This is one of our taxis, literally. And this taxi would take the women to our partner clinic, the Good Health Kalma Clinic in Area 10. So one of the other features which was interesting, is that this clinic, our partner clinic, was not situated within any of the actual areas where we did our enumeration. This was about 20 minutes, like 15 to 20 minutes away from the clinic site. Sorry.
No, but it always cracks me up in Malawi that neighborhoods are called areas.
Areas, yes, sorry.
And all of us who've worked in Malawi think, what?
Yeah, so it's
Better names than that. But.
So this is in area 10, if you know the long way, and all of our enumeration areas were like area 20, 23, so it was on the other side of the river. And the reason why we actually selected outside is because they're like, the family planning reproductive health clinic space, the service provider space is saturated in the long. There are many, many clinics. But there's a real privacy distance trade-off that women face. Women are much more, like they stated the demand for not wanting to go to their closest clinic because they were afraid of being seen, and family planning is itself relatively stigmatized in some of these contexts. So women actually prefer to actually go out of their area and take our service, even if they had a clinic next door, because of the more assurance of privacy.
Does that also limit sort of contamination across the arms?
Yeah, so this was an individually randomized controlled trial. So it's all individually randomized. And so one of the challenges, of course, with an individual RCT is contamination, spillover effects. And so what we did in order to actually create some distance is that we actually created distance between the households that were enumerated. So we had like a 10 household like space. But I can tell you that in these contexts, in local communities where everybody knows everybody, it's not enough, right?
Well,
and so
value that the women are getting in the intervention are.
Right, and so the way that we could limit the actual intervention take-up is because we have those cards and we actually had personalized the way that we are tracking all of the intervention uptake. Women who are taking up the transport and the reimbursement, we know are part of only our intervention because they're part of our system. So our integrated system from baseline, from the actual data management all the way to the intervention uptake is all integrated. So women, we know who's getting all the services. Where there's possible spillover is actually information, like the counseling, right? And because women are talking, women know who's getting what service. And so what we're actually able to do in the third and the fourth year follow-up is actually track some of those spillovers. Mm-hmm. We actually have data on social networks to be able to say, who did you talk to about the service, who talked to you about the service, and where are they? And we have some sense of what the spatial spillovers are. Now with spatial spillovers, what that actually means is that a lot of the treatment effects from the second and the third year are likely to just be attenuated because the control women are also in some ways getting exposed. So these are lower bound estimates of what a possible separated or like completely disaggregated ITT would be.
There may be some initial signals about demand creation as well.
That's right. Yeah. Yeah, so we have a lot of data about if you talk to them about it, what would they want? And
right.
Yeah, absolutely. So, yes.
Yeah. What was the compensation or benefits for the women who are randomized to the control group?
So the control group, we gave them the brochure. So we informed them about what services are available to them. And then we also told them where the nearest clinics that they could go to. They did not get the transport and they did not get the direct reimbursement, but the reason why we thought that this would be more ethically and equitable, ethically, how we say it, clinical equipoise, right, which is always a concern, is because in Malawi and in the public sector, all these services were free of cost anyway. There were these additional elements, particularly related to transport and access, where if women had demanded these other services, they were not. But in these contexts, if women were to go to the public sector, these services will be covered for free. And yet, in spite of free services, we still see a pretty significant demand response, which is telling you something about other dimensions that women might be thinking about when it comes to their demand for services and for family planning more broadly. Is that helpful?
Yeah, it's helpful to understand a little bit more of how the spaces between the interventions and control groups are.
Yeah. So it's not a pure control group.
Yeah, exactly.
Because women are just getting informed about, so family planning might be important for you, and that family planning is free in your area, but we didn't do more than that because we wanted to have some sort of comparison.
Yeah. It's a contamination perhaps of community and women talking and sharing information.
Yeah, so that is always a risk, and so one of the things that we're now actually doing is that we're like with the ministry and we're having discussions about how we can scale this up into a cluster design. Even within cluster designs in Malawi, like given how contiguous and connected so like communities are even across villages, it's pretty hard, especially with migration. Yeah. So this is actually our clinic. This is the Good Health Dharma clinic. These are women waiting for a visit outside. And yeah, they were partners for the whole three-year period. So, this is our RCP. So like the analysis is relatively straightforward, with just a comparison of treatment and control. But these are the outcomes that I'm happy to present to you today, and I can also talk about other outcomes that we've been investigating since. Yeah, intent to treat, right? Just a comparison of treatment. So I don't have any tables, I just have graphs. First of all, after 2 years of exposure to the intervention, women in the intervention group had a 5.7 percentage point higher likelihood of using contraception, and particularly using modern methods, relative to women in the control group. The baseline, the control mean is around 55%, so this is about a 10% relative increase from the baseline. Now, one of the things to note is that this is a 10% increase from a pretty high baseline to begin with. So the question that we always get asked is, how scalable and generalizable is this? Because in a community and in a context where services already seem to be doing pretty well, the fact that we are able to identify this impact, we would argue would be saying it's likely to be a lower bound estimate. So if we were to go to a context where access was lower, where there was less, like there were less availability of services, we would probably be seeing a much larger impact of the intervention on outcomes relative to a place where, like in the long way, where service like provision is already been. What we actually see when we start breaking down method mix is because the injectable contraception is the most widely used method, even in
You being an economist, these are 95% covered?
Yeah, these are 95%.
Or 90s?
95, right, 95, yes. Yep. And so these are all 95% confidence intervals, and what we actually see is a substitution away from injectable use and towards contraceptive implants, particularly in the intervention arm, because the injectable for so the main injectable method in Malawi is the 3-month Depo-Provera. So women have to get resupply every 3 months. They were actually switching more towards the 3-year Jadel contraceptives, the implant, particularly after 2 years of exposure to the intervention. Now, what's really interesting for us is this impact on birth spacing. So these are the survival curves, the Kaplan-Meier curves on the time, the hazard to a short birth interval. And so women in the intervention arm have a 40% lower hazard, a 40% lower risk of a short birth interval compared to women in the control arm. This is approximately, like if we look at if we translate this into like prevalences, so the probability of pregnancy over 24 months is about 7%. Women in the intervention arm about 3 percentage points lower, less likely to get pregnant. So that translates to roughly about a 40% lower likelihood of the hazard of short birth intervals. We then start looking at other outcomes, particularly related to women's work and employment. Women in our intervention arm, after 2 years of exposure to the intervention, are 5.3 percentage points more likely to be employed formally. This is a baseline of 20%. So this is like a 25% increase in the probability of actually returning to work over the 2-year period, and particularly to wait for wage earning work. So what we're actually finding is that it's not just because in Malawi, particularly for women, most women tend to work in the informal sector, but this is a long way. So the probability, the likelihood of formal sector and like wage earning work is already higher compared to the rest of the country. But even then, we still see some pretty important substitution and return back to work, signaling some of the opportunity cost of childbearing. I don't show some of the mediation analysis here, but if we start breaking this down and start looking at some of the like mediators that allow us, like what is translating like to this 5.3 percentage point increase in labor force participation, we're actually finding it's the birth spacing effect. It's the fact that there's like women are spacing, as well as the healthcare utilization effect, where women are able to actually engage more with the healthcare sector. Yeah. But I can present that in, like, there's an appendix slide there somewhere. We also have data on child, like physical and cognitive development. The children, these were women who were either pregnant or immediate postpartum. So the children who were either just born or who were about to be born of women. Children of women in the intervention arm are about 3.34 standard deviations taller for their age after 2 years of exposure to the intervention, compared to children of women who were assigned to the control arm. This is like a 0.3 standard deviation increase in height for age, or has. Yeah, which is pretty significant. This is a pretty large impact. We also have data from like where we did the mediation analysis, and this is also coming. It's about like 35 to 40% from the birth weight effect. This is actually the distribution. If you start looking over and you start seeing that the distribution of height for age, these scores are actually moving to the right. For after like from 2016, where we collected them at baseline, and then 2017 when we're starting to see the movement over. So this actually, if you wanted to translate this as stunting, is about a 7 percentage point reduction in stunting. Yeah.
Quick question,
Sure.
do you have exclusive breastfeeding rates?
Yes, we do. So
They go
exclusive breastfeeding, we have reported exclusive breastfeeding rates because like actually measuring breastfeeding is incredibly hard. A lot of this effect is actually coming even after you control for those first 6 months postpartum. So even after you look at like what lactational amenorrhea and like that exclusive breastfeeding period would do, but a lot of women, particularly in Lilongwe, are already starting to like stop exclusive breastfeeding by about 5 months or so. So
it could go either way, that's
yeah, exactly. So yeah, so we have some of that, and we've adjusted some of our results for exclusive breastfeeding, but it's very hard to measure because, and also we also took a lot of our lactation, our LAM estimates with a grain of salt, because the 3 conditions that women often need to meet in order to fulfill LAM is oftentimes like one of those 3 are not necessarily fulfilled or harder to identify. Yeah. So we also had a measure of caregiving, of cognitive development. So we had a measure of how children, and this is the CREDI score. I'm not sure if anybody's used CREDI, but it's a measure of early childhood development where you're looking at, especially for up to age 3, how do children play? Do they recognize color? Do they like how are they actually improving in terms of their cognitive and like socio-emotional development? This is really focused more on motor than anything else, but we see that the like children in the intervention arm are about 0.2 standard deviations better on that standardized measure of CREDI compared to children in the control arm.
In the absence of any direct intervention focusing on child development.
Right. So this is a family planning intervention that is now, and actually because we also have data on women's time use, and you actually see that like time use is actually changing for women in the intervention arm because they're able to focus more on children who are important. So we can break down like I mean all the mechanisms that you would like conceive of related to the quality quantity trade-off, and like how women are thinking about like the opportunity cost of childbearing and how they invest in children who are like given that they're able to space. Those are playing out.
What's the age range? Because
so this is 2 years, this is the 2-year follow-up, and these were kids who were either in utero or up to 6 months postpartum. So these are all kids between 2 to 3 years
the
old.
measurement was, they were in the age range of 2 to 3.
Yeah. So for the CREDI scores, they only are valid, I think, for up to age 3. And then because we also did the longer term follow-up for 2022, the CREDI score no longer is as validated. So we did the MDAT. So we updated it with.
We've been using the same thing.
Okay, great.
Study, that's
Credit and then
And that's credited in MDAT, perfect. Yeah, so we have the data from the MDAT that we're still going through right now, and that's more involved because then that has language now, and that has all the like
I just wanted to
recognition of age.
Okay, so they're about 2.
Yeah, so this time, because this is a 2019, this is all CREDI because that's the right age, that was the right age range for them. Yep. So that's kind of the results that I have so far, and I'm happy to talk about some of these other like components that we included, but kind of summarizing, like after 2 years of neoantigen exposure, women are about 6 percentage points more likely to use contraception, and they're really switching towards longer acting methods, about 44% less likely to have a pregnancy. And that is really translated to about a 3 percentage point reduction in the likelihood. women's work is actually changing, and I just kind of summarize the mediation analysis here, but happy to share that later if people are interested. And then downstream impacts on children, particularly because the index children, the children of women who were born, are about 3.34 standard deviations taller in terms of HAS, as well as 0.2 standard deviations better on cognitive measures. Something that I'm really interested in is because we have all the other children in the household who are also under age 6, including subsequent children who've now been born. We measure those children in the same way. So now it's interesting to think about, is there substitutability, and how are women maybe making compensatory investments in children, especially over the life course, because you now have siblings, you can now compare siblings against one another within the same cohort. So I think what's really interesting from this particular trial is that a lot of the policy discussions around family planning still to date focus on these first stage outcomes related to contraceptive use. And as important as it is to think about whether that contraceptive use actually is warranted, is there really concordance between what women are using and whether they want to use or not? This data from this trial supports a broader development story that goes towards theories of the demographic dividend at the individual and household level. So how are these investments in population actually translating and cascading beyond just the family planning reproductive health domain? So I think one of the conclusions I would say is that family planning is not just an effective reproductive health intervention and strategy, but it can also be a part of a broader development strategy beyond just the possible mechanical fertility implication. Something that, again, I would argue, and this is really going towards the process evaluation, how generalizable and how sustainable are some of these impacts, is really thinking about how were the intervention components and how was the trial actually designed from the onset with the partnerships in mind. Because one of the things that we are now doing is, everything that we've done is in direct collaboration with the ministry. So the buy-in from the onset, the support that we had to be able to actually do a lot of the dissemination and outreach, all came with MOH and RHD support in Malawi. One of the, of course, and also in collaboration with all the health service providers in the area. One of the things that we're really working on with the Ministry of Health is to actually say which of these components worked and why. And this is the challenging $100,000 question, I guess. We have data on all of the different components: transport, counseling, side effects. Side effects is not, the actual reimbursement for family planning services is very small. The average woman's about $2.50 over the 2-year period on family planning commodities. That's not where the cost is coming in. The cost is coming in as a transport. Counseling is costly in the sense of training counselors and actually hiring counselors to be able to disperse counseling services is one thing. But what women really wanted was the transport. And now, when you go to the Ministry of Health, and we were talking about this a few minutes ago, the really challenging conversation to have with the Ministry of Health is to say, if you really wanted the ROI, if outcomes related to these downstream impacts that include health, but also beyond health are what you're trying to achieve, the marginal dollar that you have to invest in, you might have to go outside the health sector. And that is the challenging and it's a problematic and challenging conversation to have, because these ministries are resource constrained. They're like, are you now telling me that I have to now allocate a budget to the Minister of Transport and Finance and Planning and Development that I had not thought about earlier? And the answer is well, if this is the outcome, if these are the outcomes you want to benchmark success of your programs against, then the answer would have to be probably, right? And so thinking about what that actually looks like and what the health sector can do within the health space before we start thinking about what these cross-sectoral collaborations or partnerships look like is a real challenge. I think that just generally in the health space, you have to grapple with. Because a lot of the impact, the transport is the most costly, but it's also the most effective. And in our 2x2s of cost effectiveness, right? We would love to, of course, be in that lovely box where everything is super cheap and super effective, but that's rarely the case, right? With the internet.
Oh no, we're just saying we're getting a bit close to time, but I think people. So, you sort of very beautifully anticipated the questions I wanted to ask about one about the intersectoral financing and how we're kind of stuck, I think, so much in narrow views of health and public health and stuff. But let me ask this question, like I was really interested that your next move then for scale was to go to a cluster randomized trial, which seems like sort of conventional thinking. But the question is, like, why? What's the uncertainty that you're trying to resolve in a cluster randomized trial, rather than taking that energy over those 5-6 years and trying to sort out, some intervention around the intersectional, financing?
So we're doing both. So the cluster RCT will do a couple things, because one of the questions that we have to also ask is, are there complementarities and interactions between each of the intervention components directly? Women who are using the transport might also equally be there is a correlation with them using the transport and them also using more counseling. So
the intervention is primarily still the counseling and the transport.
So yeah, and we're splitting those up in the cluster RCT, but in a separate space. We're also asking ourselves, what if we just do something extra health interventions that actually might have direct health implications? And so one of the things that I work on in Ethiopia is actually looking at gender transport. And gender transport, not just health is a core component and a core outcome, are women and are people accessing health generally, but also are they doing other things with just being able to facilitate mobility, which is, fundamental determinant of well-being as much as health is, right? And I think that asking ourselves that question, but being able to broaden out beyond just the health domain is something which I think just generally within public health, we have to grapple with more, because if we are taking multi-sectoral interdisciplinary approaches seriously, if we always say that, empowerment is multifactorial, well, if it's multifactorial, then that means that we must have to internalize the costs and the relative cost benefits of these different sectors and these different factors that actually contribute to well-being. So that's what we have to go towards. The other thing with the factorial design is that you can then pinpoint the cost effectiveness much more precisely. Yeah. And so that there's even though it sounds like it's a much more expensive, and it's a much more costly endeavor than doing an individual RCT within a.
So what was the cost? I'm curious.
The cost of the entire?
No, say the cost of the trial.
So it was $26 per woman per year for all services. But if you start breaking down those, where's the
variance? But it still gives me a reference.
Yeah.
Yeah, when you think about how much you spend, say, for AZT and HIV.
So the thing is that with family planning, one of the things so it's $26, but of the $26, it's $1 and some for the actual family planning commodities and services that you actually get at the clinic that everybody wants to subsidize, because that's the easiest. Of all the things that you want to subsidize, that's the easiest thing it's most straightforward within the health sector.
No, but I was just curious, your Uber company.
Yeah, my Uber company is about 70 to 75% of that cost.
That's like a startup, your Ministry of Economic Development, get some women startups.
Yeah.
I have a lot of questions.
Oh, please, yes.
I'll take just one.
Sure.
So can you go back to your labor participation estimates? I was wondering.
Yes.
So I was wondering, I understand it's for the RCT, distributions of household income that are evenly distributed between both. But I was wondering, in terms of the return to work, were there differences in terms of because I'm assuming that's going back to a job you already have, and then did you control for household income and ability to take leave, and were you also looking at new work as well?
So this is all. I'm so glad that you're asking labor questions. Yes, absolutely. So this is all work that women had not been taking up before.
Okay.
But the thing is that women are working more, they're not necessarily earning more. So when it comes to income, there's not really much of a change in incomes, in changes in household income, because women already in this context tend to work not for wages. And so but the one thing which I will say is that I don't present this result, but we also have data on men's incomes and men's work, because we also did labor force participation for men, and men's work is not changing. So what it's actually saying is that aggregate household labor supply is actually increasing, but it's not necessarily increasing aggregate income from the woman's channel.
There's a follow-up to that in terms of, because you didn't present kind of like, are you sampling from across the entire city and therefore are you also capturing different income strata or are you
Yeah,
restricting based off of
So
like?
we have, we don't have it's not quite representative of all in a long way. These are like, I would say, middle to lower middle income households to
Okay.
begin with. Because we were growing more in the periphery areas, but like, I mean, we randomly chose the areas and we did like a two-stage stratified random sampling for this, but it's not necessarily as representative of like the general elongated woman in that sense. This is like a little bit further down, like this woman is a little bit more on the lower middle income distribution portion of this.
They weren't necessarily working the poor.
Not necessarily, yeah, so there were, I mean, labor force participation in this context was about, formal labor force participation was about 18%.
Okay.
Like when we started the baseline, and then it increased to 20% in the control arm, and now it's about 25% in the treatment arm.
I have a question about this. Were there also differences by the number of children women already had in terms of participation?
I was gonna ask, was there a parent?
Yeah, so parent difference. The interesting thing is that for work, the answer is yes. For a lot of the other, like for a lot of some of the other outcomes, we did look at heterogeneity by like education, by parity, etc. One thing to note is that there's not as much variation in parity as you would like to believe, because these are also younger women. So a lot of them had just started, like so for a lot of women, this was their first child, particularly on the younger age of the distribution. But like there's some variation with like someone who had like this is their second or their third child. But the third child is much more rare because of women already wanting to space pregnancy at 35, between the 15 to 49 like reproductive age range, 35 is actually like pretty in the
So it's
middle.
more of 1 and 2.
Like, exactly. So they're all usually in parity 1 and 2
Okay.
if they have conditional on there being parity in this group.
Beautiful.
Yeah.
Nash, we made you work overtime already. We talked about like labor force participation, like, yeah. Thank you so much.
I'm
Yeah,
going to ask you
really
my
great.
favorite question.